start the third webinar. I'm Christos Kouimtsidis, a consultant psychiatrist from the UK. I'm also the drugs coordinator for Greece. And together with Shalini, we were lucky to take over the chair of one of the most successful interest groups of ISAM interest groups. Is that right? Thanks to Hamid, Pani, and Alex and other colleagues, they set up the first two webinars, an opportunity to share experience. Usually we're forced to share experiences when we're facing crisis. Let's hope that this good practice will continue. And Shalini will introduce the agenda today. The third webinar is divided in three parts. For the first 45 minutes, we'll have some presentations from organizations and institutions like the WHO, the Pompidou group, the representative of the therapeutic communities, and an update from service users' perspective from input. And then for the second part, we're going to have some feedback from countries. We'll start with countries that they are entering the wave of the pandemic, and then we'll move on with countries that are preparing for exit. And the last part, we're going to have a presentation about the managed alcohol program from Canada, then the interim results from the survey, global survey, and then we're going to have some time for discussion, hopefully 10-15 minutes at the end, and about the way forward. There are three themes that we ask all the presenters to take into consideration when they give their talks. The first is about the different waves that different colleagues are dealing with this pandemic. The second has to do with the risk of stigma. And the third has to do with, what was the third one? I guess about alcohol, because we talk quite a lot about drug services. Drug users are very much marginalized group, vulnerable group of the population. But don't forget that alcohol is a killer, and people who are dependent on alcohol, they might face similar or even worse problems than the drug-using population. So without any more delay, and if we are fine, should we move with Vladimir? Vladimir, are you ready to take over?
Yes, I'm ready if the slides are on, so we can go ahead. And let me start with the words of appreciation to ISAM for this initiative and for this opportunity to present an update from the World Health Organization. And if we can have the first slide, which in fact describes the broad range of responsibilities of the World Health Organization, which is at the center of the global response to COVID-19. And the guidance, and next slide, please. Next one. And the guidance from WHO, of course, covers a very broad range of issues, from the advice to general public to special initiatives in research. Next slide, please. To special initiatives in treatment research, in building capacity in less resourced countries, in providing essential supplies for COVID-19 responses. On this slide, you can see how the different activities of WHO are reflected on the WHO webpage. And today, I will highlight some of the issues related to public advice, including on the main topics of this webinar, on strategies, plans, and of course, rolling updates. And the next slide, please. The next slide, please. Can I move slides myself? No, probably not. Okay, so this is the previous one, please. This is the situation as of 6th of May, but the figures are already changing. And today we have 3.6 million confirmed cases in the world, with 83,000 of new cases and 248,000 deaths in the world. And you can see that the situation is very different in different regions of WHO, with the leading, definitely understandably, in Europe, driven to a large extent now with the situation in the Russian Federation, in Americas, driven by the situation in the US. But the third place is not Western Pacific, where the China is located. It is the Eastern Mediterranean region, with Iran, with more than 100,000 confirmed cases, and then Western Pacific region. Next slide, please. If to speak about the public advice, and in WHO, we have a very strict and centralized procedures for clearance of all communication related to COVID-19. And you know that in recent time, from some governments, we have a criticism on the actions of the World Health Organization at the beginning of the epidemic. And yesterday on our website, the new video presenting the arguments that, in fact, WHO, and this is largely based on interventions, on speeches of our Director General, Dr. Tedros, which reflects a very different picture, that WHO took actions very promptly at every stage of development of the pandemics. But in any case, that's why, because of these centralized issues, and also because the overall guidance from WHO cannot go into multiple technical areas, like, for example, addiction medicine. So that's why our intention and our current approach is to integrate as much as possible the messages from different areas into more consolidated communication packages and more consolidated guidance from the World Health Organization. And if to speak about the advice to general public related behaviors, some behaviors in our field, you can see now that some messages, like drinking alcohol doesn't protect you against COVID-19 and can be dangerous. And some of you may be aware of alcohol poisoning cases in Iran, with hundreds of people dead because of ingestion of alcohol, with the belief that it can help to protect from COVID-19. Also, we pay particular attention to prevent using alcohol, drugs, as well as gaming and gambling as coping strategies with stress. We also pay attention to potential harms that people using in intoxication can present to family members and to those for whom they care for. So next slide, please. Also, I think at the beginning it was mentioned that alcohol is not very well covered in the previous webinars, but also in our shop we pay attention to addictive behaviors and gaming and gambling, also in our messages to the general public. Just on 5th of May, a few days ago, there was questions and answers posted on WHO website on health issues within COVID context for adolescents. And there are two messages that you can see on your screens. It's about, first of all, it's about the balance between screen time and non-screen time. And second is about the position, which is not changed, this position of WHO, that we recognize gaming disorder as one of the disorders due to addictive behaviors, and we remind the adolescents, their families, about the risks of gaming disorder, which is associated with very excessive gaming. And now, as you know, probably we have the evidence of increasing using video games and internet platforms in all affected countries. Next one, please. When it comes, many of you are directly involved in provision of services for people with substance use disorders. As I already mentioned, at the moment, there is no very specific guidance from WHO on organization of services for substance use disorders during the COVID outbreak. However, we have And next slide, if possible. Yes, we have these operational considerations for case management of COVID-19. Previous one, please. Previous one.
Sorry, it's a bit slow. I'm just trying.
Yes, it's significant delay. Yes, but there is operational considerations for case management in COVID-19 in health facilities. On previous slide, not that one. This one. Yes, it's dated 19th March, and we expect that soon it will be updated with more guidance on exit from from severe restrictions due to COVID-19 pandemics. And these operational considerations are applicable to different health facilities, and it's designed across different stages of development of pandemic. Now, please, next one. Well, so these guidelines provides this interim guidance. Next one, please. This one. Yes, it provides guidance at different stages of development of pandemic, from sporadic cases and introduction of emergency to the exit from restrictions. However, mental health, as you probably know, has been a priority area for WHO in emergencies for many years, even before the COVID-19 pandemics. And there is an interagency standing committee, which is a particular body within the UN system to deal with emergencies. In February 2020, there was a special interim briefing note produced by this Interagency Standing Committee, which is co-chaired by the World Health Organization. And in this is the document that provides more detailed guidance from WHO on mental health and psychosocial aspects of COVID-19 outbreak. We developed the annex to this interim briefing note, which is currently under clearance of principles of the UN organizations, which combine this, which are part of this interagency standing committee. And in this annex, you will see the messages which are much more specific, which are related to general public, to people with health conditions caused by substance use or addictive behaviors, and to service providers and policymakers. And we address such issues like continuity of opioid agonist maintenance treatment, like considering as essential services treatment for substance use disorders. We are considering the issues related to overdose, to withdrawal management, and also some general advice, as well as on policy regulations, which are particularly relevant to alcohol and gambling. So I would advise to see when this document will go out, and we will share it with ISAM for dissemination if you feel it's appropriate. Next one, please.
Vladimir, 1 minute.
When it comes to stigma, I have 2 slides left. When it comes to stigma, then there is also a partnership communication with International Red Cross and Unicef, which contains three major strategies of dealing with social stigma associated with COVID-19. And again, I refer you to the documents themselves, because I cannot go into any details on that. And you can see that it's pays special attention to the language, to some ideas which you see on this slide on how to drive stigma away, and on communication tips and messages. And the last slide is about the exit from social restrictions. Globally, we don't have now a very clear guidance on different last stages of the restrictions, but the European Regional Office produced one. And what is interesting that in this document, they talk about the 3 phases of social and economic impact of COVID-19, where definitely alcohol and higher prevalence rates of vulnerable populations of COVID are reflected. This is a long-standing task, and I think for all of us, the major task now is to document, collate, and learn from the lessons learned in the countries to increase our preparedness for future emergencies. And in WHO, we stand ready to work with all partners and with ISAM on making us better prepared for such emergencies in future. Thank you. Stop here.
Vladimir, thank you very much. Thomas, are you ready from Pompidou? Hello, Thomas.
Christos, I am. Can you all hear me?
Yes, I can hear you. Everybody?
Well, looks like it. Yes, first of all, I would like to keep the slides till the end. I will ask them to bring them up. And secondly, Christos, I'm sorry to having to disappoint you. I have now, can we please leave the slides for now? Thank you. Just leave it like that. Perfect. I have to apologize. I will not be able to address the issue of alcohol, which is due to the fact that the mandate of the Pompidou Group does explicitly not encompass alcohol, but only illicit substances. So unfortunately, I will have to disappoint you on that one. But as we heard from our colleague Vladimir, WHO is well placed to deal with the alcohol aspect and no need for the Pompidou Group to do an overlap. Yes, we all have to be attentive to concerns about stigmatization of people suffering from substance abuse disorders as a result of the global COVID pandemic. Under the present circumstances, there is a risk of reduced political and societal acceptance of addictions and drug use in such a climate. In addition, people who use illicit drugs suffer in such a situation explicitly more from the compounded stigma of being seen as a criminal. And we have to be alerted to the fact that it is projected that COVID-19 will lead to an unprecedented global recession. Luckily, we're in the position to learn from previous economic crisis situations. We know today that economic crisis and financial constraints affect all determinants of health. Such effects predominantly impact vulnerable groups, of course, and bring about an increase in drug use and addictions. Studies show a worrying correlation between economic crisis on the one hand and negative public health trends with high risk of discrimination. We can observe a relation between mortality and morbidity trends and the capacity or lack of capacity of health systems to respond to an increased demand for care. We know this from the 2009 financial crisis, and the resulting austerity measures impacted negatively on drug use patterns. Just to illustrate, there was an increased use of cheaper and more dangerous drugs observed. There was increased incidence of polydrug use involving both illicit and licit substances, notably alcohol and prescription medicine. There was an earlier onset of drug use recorded, particularly in connection with increased youth unemployment. And of course, there was a much higher risk of former drug users relapsing, either for lack of accessibility of services, for emotional, psychological reasons, or others. And we have seen in this situation a shift also to riskier patterns of taking drugs. An observed increase in the HIV mortality and morbidity at that time was linked to reduced levels of harm reduction services and a reduced availability of opioid agonist treatment. Overall, trends then showed an increase in the number of HIV infections, alcohol-related deaths, suicides, and mental health problems, particularly in countries severely affected by austerity measures. The stigmatization of people dependent on drug use increased in countries with these austerity measures dramatically, where resources for so-called legitimate causes, such as cancer treatment, are scarce. Drug dependence is in the public often seen as a moral failure, resulting in the resources dedicated to treating drug-dependent people becoming the first target for budget cuts. And this is unfortunately little publicly bemoaned. As a result of the diminishing social tolerance and support, drug users are increasingly faced with stigmatization. We have to be aware of that. And this aggravates, of course, their health status and undermines chances of making a full recovery. In such situations, political decision makers in particular also face mounting criticism when advocating for adequate care for people with substance abuse disorders. We have to see that. For those in detention, it's even worse. Regrettably, budget cuts often affect specialized treatment programs in prisons first. As a result, prisoners with drug use disorders may face undue restrictions when accessing treatment. However, we must not forget that governments and professionals working in public service have obligations under international and national legal instruments to safeguard fundamental standards of human rights. These include the right of life, the right to protection of health, the right to non-discrimination, and the prohibition of inhuman or degrading treatment. The prohibition of discrimination, by the way, includes the right not to be discriminated against because of health status. And the right to protection of health includes the equivalence of care for those in detention. These are obligations for governments, and governments can be held accountable on these issues. But what else can we do? How can we actually make concrete steps to avoid stigmatization and discrimination in our daily work? First of all, I think decision makers must be reminded that there is a requirement to observe national and international human rights obligations in the planning of measures, but also very important in the allocation of resources. It's a very important indicator. Secondly, all those working with people who suffer from substance use disorder should be conscious of using non-stigmatizing language. And I'm very thankful that Vladimir already mentioned that. It seems like a small step, but it does make an important difference. First of all, for oneself, but also for the people you regularly communicate with. Also, we must recognize that some people in need will not access help by fear of stigmatization, and because they have difficulties in accessing services because of reduced availability of resources in general. Therefore, we must be proactively reaching out to those in need and not wait till they come. We still too often have mentality to sit and wait till people come. We must encourage and potentially increase in this situation our outreach capacities. We must furthermore provide concrete practical measures that can help to ensure accessibility. Some of them are very simple, but they can make a big difference. We have seen that free transportation for patients to go to treatment programs or to harm reduction centers and rehabilitation services makes a huge difference in ensuring that people can receive the services they are in need of. Secondly, one should at any cost avoid patient charges in primary specialist care. For example, patients who cannot afford the co-payment will not be able to get a prescription for an opiate agonist treatment, etc., etc. By being conscious of the rights of people with substance use disorders and the negative impact of stigmatization on the individuals, but also on society at large, we will take the right decisions and actions, I'm convinced. It's about our consciousness, first of all. And we must not forget that every step we do to prevent discrimination is a contribution to a humane drug policy, and at the same time, an effective measure for ensuring public health and also containing the virus. Could we have slide number 1 now, please? The Pompidou Group has set up an online platform last week, actually, to share experiences to meet the practical challenges resulting from COVID-19 pandemic. In situations of crisis, human creativity often brings about much needed ideas for first-hand solutions. The Pompidou Group provides, therefore, a platform bringing together such examples. We seek to inform the global community about practical measures which are in use and experiments that aim to protect the health of people who use drugs and at the same time contain the risk they spread the virus. The This platform is a tool for decision makers and for practitioners, and offers online examples of practices that are aimed at mitigating the adverse effects of COVID-19 and discrimination. Could we have slide number 2, please?
Thomas, your time is up. Yeah.
Yes, and this is the last slide. Thank you, Christos. And I hope you will appreciate that. For further use, I would like to recommend to you the Athens Declaration of the Pompidou Group, together with the explanatory memorandum, which sets out the essential services to be offered to drug users and to avoid discrimination in times of crisis and in times of financial constraints. Thank you all very much for your attention.
Thomas, thank you very much for that rich presentation, thought-provoking presentation. Can we move on? Fedon, you are online now. Are you able to take over?
Yes, I can. Can you hear me? Can
Yes.
you hear me now? Great. Well, I would like to start with an apology because I was not able to be connected through my laptop. I don't know why. So I'm on the phone and I can see only the person who is talking. So I cannot see everybody. I just saw Christos and Thomas and Vladimir. Hi, hello everybody. Okay. I will give you an overview briefly, an overview of what is happening with therapeutic communities, not only in Europe, but because I'm also the vice president of the World Federation of Therapeutic Communities throughout the world. Let's go to the second slide, please. Okay, this is EFTC, the European Federation of Therapeutic Communities. The next slide. Because these are not very important slides. And the next one is the one that really will give you an idea. Thank you. About the obstacles we're facing now, this specific treatment model, therapeutic community, which is not only a residential treatment approach, but we also have non-residential programs all over the world, has these 4 difficulties. First of all, the model itself is based on group intervention. And now it is very difficult to, because of the required social distancing, it's very difficult to have these sessions. We do have them with difficulties. So it is not easy. That's one thing that we are facing in the therapeutic communities. The second one is that also physical proximity is very important. Probably for another model, it is not so, but for us, I mean, we are a tribe, as I used to say, a tribe of huggers. So bonding, hugging, physical touch is important. This cannot be done. Also, in residential programs, residential TCs, residential therapeutic communities, people experience a lot of stress, a lot of anxiety. There is fear, there is boredom, of course, loneliness, and anger, and even insomnia. So this is something that we have to take into consideration. And the last point that I want to make, which is really is in the long run, but we are going to see more and more of this, is because of the rise of unemployment, because of the coronavirus spread. We are going to have difficulty encouraging and helping and assisting our clients to reintegrate into society by finding a job. I mean, you can understand. We can all understand this. So let's go to the next slide, please. Now, what happened? It varies from country to country, of course, because each country has its own regulations. But in most cases, when there was a lockdown, we were not allowed to have intakes, to accept people into our programs. Now, for example, here in Greece, we can do this, but only after testing. So people have to take the test. If they are tested positive, then they are referred to a hospital. If not, they enter a residential program, therapeutic community, and they have to stay in isolation by themselves in one room for 14 days. That's the usual protocol across the board, all over the world. We also provide, in most cases, we are able to do this. We provide PPE for all staff and clients. We do all the family therapy sessions with the families involved online. And in cases of people who want to come to the programs, or of people who are out in the re-entry phase, the last phase where they get reintegrated with society, we do the counseling again online. And in some cases, we have to create, let's say, new protocols and find new activities to involve the people, especially in residential TCs. To give you one example, here in Greece, we have a big problem with people who are homeless. And for the very first time, because of the coronavirus, so something good came out of it, together with the other national organization, OCANA, which is a harm reduction organization, my organization, Kethia, started a hostel for homeless users in Athens. So, and that's a new, that required a new protocol, and this is a new endeavor for us. Or in the Philippines, for example, where things are very strict because of the policing there and what the president wants, people have to stay. They cannot leave. Even during the weekends, they cannot go home. They cannot leave the residential program. So people had to find the staff there, had to create new activities to keep the people on track, let's say. So more or less, this is what is happening not only in Europe, in therapeutic communities, but more or less around the globe. I think that's all. Thank you. And if there are questions at the end, I will be more than glad to answer.
I think that
I was on time, Christos, I think.
Thank you very much on time.
Yes.
We are
Although Greek, Christos.
keeping on time, yeah. But if we have questions for each one of the presenters, we can use the chat box and ask those questions. Is that right? Panier?
Yes.
Can use, yeah, good.
Yes.
So
We
if you
will
have
take
any
care of
questions,
questions at the end of the session.
and then we can answer them at the end of the session or individually between each other. So, Stephen, are you ready to take over and present an update from the input?
Yes, I hope everyone can hear me okay, yeah?
Yes, we can.
Good morning.
Yes,
Good
please.
afternoon. My name is Stephen Malloy, and I am speaking on behalf of Input. Input is the international network of people who use drugs. We are a global peer-based organisation composed of former and current drug users. And we seek to promote the health and defend the rights of people who use drugs. We were established and born from the Vancouver Declaration many, many years ago. And the organisation spans the globe through its connection to its regional networks. I myself was on the board of Input as the regional representative for Euro Input. And we have a strong collection of regional networks who support the domestic and in-country network development of people who use drugs. We recognise this time as being a time of great uncertainty for many people who use drugs. We echo the position of the United Nations Human Rights Officer for the High Commission, who noted that people who use drugs face unique risks in this current climate due to the criminalisation, the stigma, the discrimination, and of course the underlying health issues, the social marginalisation, and the higher economic and social vulnerabilities that they face. This, of course, also includes, the lack of access to adequate housing and healthcare that many people who use drugs often face. Vulnerable groups of people who use drugs should be recognised as high-risk populations in order to mitigate the spread of the pandemic. And of course, many countries have taken excellent steps to do what they can to recognise that vulnerability. However, there is a backdrop, and I'm sorry if perhaps this has been covered before. Can we move on to the next slide, please? And I think it's absolutely critical that we remember that backdrop before we begin to talk about how we exit this pandemic. As noted in the World Drugs Report by the UN in 2019, we have some 35 million people who meet that criteria as living with a drug use disorder, and some 585,000 drugs-related deaths. Now, half of those deaths, as most of you will be aware, are as a result of untreated hepatitis C. Just as an example, so I understand we are talking about the number of deaths through COVID-19 infection, but let's not forget that we already have another crisis unfolding that has been unfolding for a number of years. In many parts of the world, over the last couple of years, we saw a huge increase in both illicit fentanyl and illicit benzodiazepines entering the market and causing all sorts of harm to people who use currently illicit drugs. You can see in the slide there, I suppose, the shape of this issue that we all face in our communities with the variety of different illicit and controlled drugs that are being made available and misused. But despite all of this, only 1 in 7 people currently get access to any form of treatment. Now, that in and of itself presents huge problems, as everyone knows. Can you go on to the next slide, please? Particularly when all of the recommendations that are made from UN bodies, including the High Commissioner, relate to the provision and accessibility of low-threshold harm reduction services. Now, some countries have, taken great steps, and indeed here in the UK, patients are able to receive their OST, their opioid agonist therapy, sometimes delivered to their homes. And this is the same when it comes to injecting equipment and other drug use paraphernalia, but this is not the case, obviously, in every country. The spread of harm reduction services, as was very eloquently discussed by Thomas earlier, had seemed to be stalling since about 2012, and many of us recognised back then that the financial crisis, austerity, meant that these vital services were not being scaled up in the way we need them to. You can see there from what has been increased in terms of NSP. Just last year in 2018, it was only 1 country. Now, we see how vital access to NSP is. And again, the UN has mentioned this, but if we look across different regions, we find that in Asia, for example, only 15 countries out of the 26 actually have 1 OST program. That's the same for access to NSP, but only 2 have naloxone, for example. In Eurasia, if we think of the Eurasian region, only 6 countries have access to take-home naloxone out of the 30. Of course, it's different as you move further west, but ultimately, we still have that limited access where, at this point in time, the thing that the community needs the most is enhanced access and low-threshold access. Can we move on to the next slide, please? Many of the key issues that have already been discussed, we at Input and our regional networks also agree. The right to health fundamentally is the most important thing that must be protected in this current context. Harm reduction service provision seen as, and those involved in the delivery of those services seen as essential key workers has been something that has been of great value, certainly in this country, and it would be hoped that other countries who perhaps are earlier in the wave of this pandemic would also recognise just how essential these people are when delivering, let's say, secondary NSP or backpack needle exchange, delivering methadone, operating mobile needle and syringe programs. All of these things should be recognised as as essential key workers. And that's the same for the rapid and low threshold access to opioid agonist therapies. In the UK and in many other countries, it would often be the case that patients went through fairly long-term supervision and a need to attend community pharmacy. But we saw how quickly that falls away in light of this current pandemic. Many more people are being afforded the opportunity to manage their medication, to have the autonomy to do so, and be respected and seen as having the agency to do so. And that must be something that's continued as we go forward outside of this pandemic. Access to accommodation has been mentioned. You know, my own city, Glasgow, we have a HIV outbreak in this city, which was fairly new. It wasn't thought that HIV outbreaks like this would happen again in countries such wealthy countries as ours. But we very quickly took action to try and alleviate the homeless population issues that were there, and found the resources to accommodate people in single occupancy spaces. Now, granted, physical distancing, social distancing as an illicit drug user is almost impossible. And that brings us on to, I suppose, the other point there of even the detention settings in prisons. We've taken steps to look at ways to reduce the prison population in various countries, but some countries, frankly, cannot do that. We currently have somewhere in the region of 1.2 million people behind bars for drugs-related offences, and more than 500,000 of those people is merely for possession offences. These people have to be, of course, liberated from these dangerous environments, the prisons, but we also have to be thinking about where they will be accommodated, of course, and supported. And we also have to be sure that the emergency powers enacted by states aren't used against certain communities or groups, including people who use drugs. It's absolutely vital that our rights are still maintained and protected as best possible at this current time. Finally, one of the most crucial things, and one of the most positive steps for some of this, is the amount of engagement online that's taken place to compile and share really meaningful and useful information for people who use drugs. And if anything, again, that's something that hopefully will be further developed and will help to further enhance the contribution of people who actually use drugs in these discussions and debates around how states should be responding to their needs. On the last page, you'll see some resources that were created by Input, supported by CanPud in Canada, translated into a multitude of languages. It's on the last slide, please. And shared and disseminated widely with a range of other harm reduction and civil society partners. We recognise that the stigma associated, in fact, the stigma that criminalisation uses, frankly, to maintain this status quo that we have, will continue as we exit this pandemic. We hope that many more people are able to access services by accessing online services, online support, telephone helper support, and perhaps more people will access treatment because there'll be less of an expectation that they present to places that are so heavily stigmatised all of the time anyway. I look forward to the discussion and thank you very much. I hope that was in time.
Stephen, thank you very much. And I hope that there will be no objection from Shalini to invite even now Stephen to join us for the final COVID webinar in September, when we look into lessons learned. The voice of service users is crucial, and we'll try to invite as many organizations and international organizations as possible. That concludes the first part of the webinar. Thank you to all the presenters for being on time and rehearsing very well their presentations. Now we're moving to the second part of individual feedback from countries. We have Felix first from Brazil, then Atul from India, Gabriel from Norway. Then I will do a brief from the UK, and then Susanna, hi Susanna, from New Zealand, Shalini from Australia. We had problems with Shalini's presentation last time, and I think we China and South Korea, if I'm not wrong. But let's see how we go. Felix, do you want to take over?
Yes. Can you hear me? Yes. So good morning, everyone. Thank you very much for the invitation. It's an honor to be here. So I'm going to present.
There is a lot of echo, Felix.
I think
Can we sort it out, Pernian?
Christoph, you need to unmute. You need to mute yourself when Felix.
Yeah, I do that, Hamid. I do. I keep it mute all the time. Yeah. Okay. Go.
Okay. So thank you again. So maybe Dr. Tom going to present a brief overview of the scenario.
Felix, are you using two different computers or two different accounts or one phone and one computer? Because we can see that you have two different names on your account.
Okay. Let's see. Okay.
Yes.
Go ahead. Now we can hear you well.
Go ahead. Yeah, we can hear you very well.
Great, thanks. So I'm going to present a brief overview on Brazil scenario. And as you know, we live in a very big country with more than 200 million people, and most of them are poor. And unfortunately, there is a high probability that in the next month, we will be the next world's COVID epicenter with a lot of deaths. Right now, our numbers and rates are rapidly increasing, and we have more than 600 deaths a day. However, Brazil has a relevant lack of testing, and we don't know the exact numbers. There's a high probability that we have 10 times more infected people than the official numbers. Luckily, I live in the most southern state capital of Brazil, which has a European culture, and my city is called Porto Alegre, and we have the best tests, the best rates in the country. So regarding substance abuse, our main problems are related to alcohol, marijuana, and cocaine or crack cocaine users. And we know that the numbers of alcohol and marijuana use at home is increasing. Brazil is the major crack consumer in the world. And as you can see in the slide, we have the biggest cracklands with more than 300 people in the streets, and they use drugs and they sell drugs without masks, of course. So it's very dangerous for them. This city is called São Paulo. Is the biggest city in Brazil. We also know that many of inpatient and outpatient clinic were closed due to COVID epidemic, and we are concerned about access to treatment and domestic violence once they have to stay home. Also, our government have been investing in therapeutic communities, which is good, but we know that in Brazil, they do not have good sanitary conditions to protect people from transmission. Can you put the next slide, please? One more. We analyzed some data of our patients. We found out that they have higher prevalence of clinical disease than general populations, like
heart disease, diabetes, fibrosis. And this could increase risks of mortality by COVID infection. So we're concerned about that too. The good news is that our health system is universal and people have full access and free access to primary care and hospitals, although we will not have vacancies for everyone, and people are dying because of it. Finally, can you put the last slide, please? We are working to create guidelines, protocols, in order to help public policies and in order to increase prevention strategies and access to treatment. And we also have been conducting studies to understand the substance abuse problem and their consequences related to epidemic right now. And we will be happy to share some of the manuscripts we are writing on this. So that's it. Thank you very much.
Thank you very much, Felix. I gave you a bit of extra time because of the technical problems. Atul, are you ready to take over? You have 3 to 5 minutes maximum. Try to keep it on time. Thank you.
Yes, I'm totally ready. Am I audible to everyone?
Yes, we can hear you.
Right. So as we can see here in the top row, these are our COVID-19 numbers. The epidemic has just crossed 50,000 mark. It's still rising. The curve doesn't seem to be flattening really in India, despite the most strictest lockdown which the country has witnessed ever. The middle row shows the burden of substance use disorders which we have in our country. And as we can see here, there are millions of people using and suffering from use disorders of alcohol, cannabis, and opioids. And even in the best of times, the coverage of services has been rather low. So there has been a large treatment gap, and the biggest challenge in the nationwide lockdown since 25th March has been serious restrictions on availability of both drugs as well as treatment access for people who are using drugs. Next slide, please. In fact, as soon as the lockdown was announced, there was severe curtailment in availability of alcohol. No, previous please. Yeah. So as soon as the lockdown was announced, there was curtailment in availability of alcohol, and we started seeing previously. We started seeing a lot of cases presenting to us with alcohol withdrawal. The telephone calls on the helplines, there was a severe jump in number of people calling for help. And as soon as they have opened the alcohol shops again, just 2 days back, we again see a lot of crowds on the streets in front of these alcohol shops and all social distancing going for a toss. So what all we have been doing is what I'm going to talk about. Next slide, please. The first task which we had was to issue advisories for general public in the form of various documents, infographics, or videos. And for this, we contacted government agencies, and as official advisories, we released these kind of documents in the public domain to help people suffering from alcohol use disorders and drug use disorders seek appropriate help. Next slide, please. The next task for us was to explore whether we can provide at a distance consultation to patients. The officially telemedicine guidelines have been recently released by Government of India. Unfortunately, most of the medicines that we addiction medicine professionals use, they are not allowed to be prescribed at a distance. So that's our advocacy work, which is still ongoing. Next slide, please. The very next thing which we wanted to do was to ensure that our professionals, particularly on OST or opioid agonist treatment, they remain aware of the revised kind of situation and the guidelines are modified accordingly. So the Indian Psychiatric Society as well as the government hospitals and their networks, as well as the National AIDS Control Program.
I want to be get naked and feel a man inside me, my mouth and in my breath, enjoying each other's bodies, kissing and licking and tasting.
We have someone interfering.
Is it only me? Yeah, right. So all these set of guidelines have been produced and released, and the general principles which all these guidelines contain is about ensuring continuity of services, ensuring safety of patients and service providers, and most importantly, a more liberal drug dispensing regime. Take home the buprenorphine, naloxone, as well as methadone. The methadone take home is in fact something which we tried first time during this pandemic. Next slide, please. Next slide, please. Besides all these measures, there was also important to provide training and guidance to our addiction medicine professionals, and a lot of forums and measures were created to achieve this. A large number of webinars are being conducted to be in touch with the addiction medicine service providers. Online training programs have been started in the form of crash courses, just 3 or 4 hour crash course. Any physician sitting anywhere can access these free of cost and get some refresher in capacity building for treatment of alcohol and opioid use disorder. Next, please. We are also in touch with our service providers and getting information from them. Yes, I'm just concluding. So the general impression which we are getting is that alcohol and illicit drugs continue to be available in the lockdown, though with difficulty. There is a reduction in footfall, and most importantly for us, despite liberal take-home, there are no instances of diversion of either buprenorphine or methadone. Next slide, please. The next slide will show us some of the pictures of social distancing being maintained in our static as well as in our mobile methadone clinic in Delhi, as well as the take-home dispensing of methadone for which our patients are also now cooperating with us. Next slide, please. So in conclusion, one can really say that the worst is yet to come. We still don't know what the substance use situation is going to be in the post-COVID world. And it's high time that we restart and reimagine the policy and practice of addiction medicine. In fact, this can be a good opportunity for implementation science research. In general, I believe that we will have to adopt a more liberal perspective towards practice of addiction medicine, erring more towards the side of providing access to people rather than restricting access for fear of diversion, etc. Next, please, this is the concluding slide. We are very pleased to announce the registration of our professional society, Addiction Psychiatry Society of India. Because of these lockdown measures, many of the formalities are still ongoing, but at least the formal registration with the authorities is complete, and very soon we are going to start the membership drive. Thank you very much, everyone.
Thank you, Atul. Thank you. Can we move to Gabriel, please, from Norway? Gabriel, are you ready?
I'm ready.
Excuse me, can I interrupt? It's Susanna here. We have an imposter who has joined us. There's a very rude video happening.
Is there any way we can block that, Panin or Hamid? No?
I tried to dismiss the spam bots. Are they gone? It's disappeared off my screen now, so I don't know if you've managed to get rid of it.
All right, Gabriel, let's start.
Okay. Can I have my yes, thank you. Good afternoon from Norway. I'm going to say something about the COVID-19 situation for substance users in Norway, both in Oslo and Bergen, and a survey we are about to undertake. In the right upper corner, you can see Europe, and the color of the countries shows how many deaths there are in the death rate in different countries. And Norway is far to the north and west, and you see that we are pretty well off so far. Next slide, please. Norway is a wealthy country. We have only 4.5 million inhabitants. And in my opinion, the government has had a quite firm hand with the COVID-19 situation so far. The society was partly closed down on March the 12th and has gradually been opened up since 20th April. We have so far tested 190,000 people. There are 8,000 registered as infected with the COVID-19, and there are 215 persons dead. That is figures from 2 days back. You can see from the curves, which is the timeline from 25th of February until today, that the numbers of patients admitted to hospital, to intensive care unit, and to ventilators have peaked some time ago. And if I can have, yes, yes, and the next slide, please. What about the substance use and COVID-19? In Oslo, there are approximately 700,000 inhabitants, and 2,500 people have been shown to be infected with COVID-19. So Oslo is the epicenter in Norway. I took a round the other day with the hospitals in the Oslo region, and very few of the sick people in Norway have been substance users. That's a bit surprising. Most services for substance users have been kept open all the time during the pandemic. And in Oslo, the municipality of Oslo, there's only been tested 85 substance users, and 2 of them were proven to be positive. We do have in Norway, as you see from the right and the upper right part, we have open drug scenes, both in Oslo and Bergen. And in the end of March, a corona isolation unit for substance users was opened in Oslo. We are well manned with nurses, social workers, and me as medical doctor, and we are well equipped with plenty of PPE. The main purpose of this unit is to stop and limit the spread of the COVID-19 in this vulnerable population. We have a liberal medication policy, and of the 7 substance users who have been admitted so far, it was surprising for us to find that 6 of them were born either in Africa or Asia, and 5 of them were using primarily alcohol and cocaine, which also was a big surprise for us. The 2 opiate users, one of them on heroin, the other one on prescribed drugs. Last slide, please. So to find more out about the situation in Norway, we are about to undertake a survey of active drug users who are part of the open drug scenes in Oslo and Bergen. And the purpose of our survey is to find out which substances they use and how the COVID-19 infection has influenced the substance use. We also want to know about what they know about the COVID-19 related symptoms and if they have any current symptoms. And also, what are their attitudes to having a COVID-19 test if they have symptoms? And we also want to know what do they know about the available services to COVID-19 infected users. So what is the status and further plans regarding the survey? We do have a close cooperation with users organization. You see to the bottom left, we have a COVID-19 bus, which is run by one of our user organizations. It used to be a Hep C bus and it's been converted into a COVID-19 bus. As interviewers, we want to use both peers and we also want to use professional outreach workers. And we aim to have approximately 100 participants from Oslo and the same number from Bergen. The questionnaire is now being piloted and going sent through the ethical committee, and hopefully we'll be able to start next week with a survey. The aim is to use the results of this survey to target the treatment and follow-up measures for this population. Thank you.
Thank you, Gabriel. And I think you have to come back and present the results of the study in September. Yes?
Yes, I will.
Yes. I have another meeting happening at the same time, which Too many messages on my screen.
You can skip that. Yeah.
All right. So this is my slide. 5 minutes an update from England. As I said, I work as a consultant psychiatrist with an NHS service, provide service together with a third sector organization. And I will summarize on the left, you will see the situation now with opiate substitution treatment. On the left, what are the plans for tomorrow, how to gradually get back to what new normality might be. As you can see, one of the stuff that we have done immediately, we became flexible regarding working arrangements, working from home. I suspect this is happening with a lot of other services. We are very flexible now with face-to-face appointments, even when we have to start prescribing. So, for example, if the client is new to us, then sometimes we can start prescription without. Pardon, I have lost the slide. Are you sharing? Can you share back, please?
Yes, I'm sharing the slides. Can't you see that?
Can you see the slides yourselves, guys?
Yeah, can you see that now? Can you see the slides? No?
Yes, I can see them. Yes.
Okay, sorry.
So we see we became very flexible. Most of the work done is over the phone. Dispensing, as Stephen has mentioned, has been relaxed very fast from daily or even daily advice to 2 times a week, weekly pickups. And so far, so good. And we start preparing the scripts well in advance. So we have scripts ready in advance, posted 4, 6, 8 weeks. Those flexibilities raised a lot of risks, such as compliance. We try to mitigate those risks with increased frequency of phone calls. So we have very, very frequent, even twice a week, touching base with our clients, the key workers, even for 2 or 3 minutes. How are you? How are you coping? And we made it clear from the beginning, preparation of the script, which is in a way guarantee the continuation of the prescription, does not mean that we don't review the needs of the client. So we separated basic continuation of the script, reviewing the titration, reviewing the doses, reviewing the risks and the needs of the clients. That was what was happening from last week, and this week we are preparing, and we are started preparing for opening up major clinics. We are covering a rural area, so we are running a lot of satellite clinics. So the major ones will open with restrictions such as glass screens between seating, between seats, large waiting areas, wherever we can do, even sacrifices, group rooms for that. We'll try to prioritize the clients that will need some reviews face-to-face. And of course, in order to do that, we need to have more PPEs, something which seems to getting to be resolved at the moment. We are going to restart testing the clients again. We had a positive reinforcement approach anyway. We're testing the clients in order to test their compliance with treatment, in order to reward change, a very kind of positive reinforcement attitude. And we have agreed that people who are given the responsibility to be even on weekly pickups, we're going to test to see if they can maintain the privilege, yes or no. And we hope to do it in such a therapeutic way so the clients can move forward. The scripts will be delivered through the post or delivered to pharmacy. We'll keep the 4 or 6 weeks in advance. It seems that the teams were able to distinguish between continuation but frequent reviewing. So we hope that we're going to retain a lot of innovation, such as the frequency of the telephone calls, the flexibility, and the positive risk-taking attitude. I think that's have changed. because of the unprecedented situations, we feel more empowered to cut corners, to customize the treatment for each one of the clients. This is a spirit and attitude that we need to maintain as a core part. You might have seen the logo: manage risk, maintain structure, maximize benefits. This is the three aspects of the work we do during the telephone consultation with all the clients. How do they manage the risk of COVID? How they maintain structure every day? Are there any benefits? What are those benefits? How we can use this isolation and restrictions to their advantage. Next slide, please. This is the second and final one. And again, with alcohol, I have to say that I'm very pleased to see that Public Health England advocated for using alcohol itself as a medication. This is the core of the prehabilitation approach that my service and a lot of other services are using nowadays. So whatever groups, they've been replaced with over the phone, modified manual. And the aim is to help the client stabilize their drinking, reduce safely if they can, and them also either inpatient detox or community detox. We don't offer home detox. We hope that will change. We hope that we're going to have access to home detox, but for the next 4 weeks, we're going to do community detoxes where needed. We're going to start smaller groups, half of the size, and reduce the duration of the groups as well. And I hope that, as I said, the flexibility that in our approach into the problem will remain even after the COVID situation is resolved. That was my presentation. I don't think I have another slide. Thank you. And let's move to Susanna from New Zealand. Hi, Susanna.
Hi, Christos. Hi, everyone. I just want to say that since you started talking, I've been blocked about 3 times and I had to restart. So that might happen. And I can't see my slides at all. So that's okay. I can still talk to them if you can all see them. Can you see them?
Yes, I think I can see them.
Yeah, I can't. For some reason, something's happened. Anyway, so this is my 3rd presentation about New Zealand, and I'm giving a bit of an update on the progress in New Zealand. My first presentation, at that time, we were just getting into lockdown, and so we were scrambling to try to deliver services in a physical distancing approach. Then in my second presentation, I was talking about the effectiveness of the treatment that we were providing. And today, I'll be talking a little bit about thinking about exiting from the alert levels and moving into the new normal. So in New Zealand, we're lucky to be in that situation because we acted early, we went hard, and we're still quite vigilant. So if you look at the second slide, it gives the number of cases that we've had to date. This is very recent data, and we've only had, we were lucky enough to have just 21 deaths. And you can see we've got nobody in ICU. Next slide, please. We have not just flattened the curve, but we seem to have squashed it. I'm using political words now by saying that. Next slide. So as I said, we're actually in the stage of preparing for our new normal. So last time that I presented, I talked about virtual clinics, and I had a couple of questions about virtual clinics because I said that we started thinking about maintaining virtual clinics post-COVID. And so I'd like to make a bit of a distinction. So there's virtual clinics where we're running OST, opioid substitution treatment clinics. And for the opioid substitution treatment clinics, what we've been doing is faxing prescriptions to pharmacies with clients going to pharmacies for pickups. But we've also relaxed some of our prescribing regimes. And how we've done this is by talking to a family member and getting them to act as an agent. So they assumed responsibility for the relaxed regime with that particular individual. We're also delivering doses in houses and in car parks sometimes where it was necessary. So of course, there's also, like everywhere else, there was a potential overdose risk because of the different availability of illicit substances on the market. And so we relaxed the availability of naloxone as well. And so luckily enough, we haven't had any major incidents. The new normal, virtual clinics, will be running alongside face-to-face clinics. So the same virtual OST clinics. What we're thinking of is that face-to-face clinics will be for those initiations and for clients with acute distress. Any dose increases as well will be based on clinical judgment. There are some clients as well who don't have smartphone availability, which means that face-to-face is practically our only option. However, virtual clinics will continue running, particularly for some groups, those living in remote areas, or those who have difficulties getting to a clinic, for example, people who work or people who have kids and things like that. We're also considering having virtual clinics running with key worker appointments doing the face-to-face, but the doctor zooms in virtually, so that because you have less medical people, then you're able to reach a larger group of people. We're also going to continue using the virtual clinics for GP support. Then the other type of virtual clinics, next slide please, is the virtual clinics that run talking therapies. And I named it talking therapies because, because we've got quite a broad range of therapies that we provide. So we've been providing individual and group sessions virtually, mainly based on motivational interviewing. And in the new normal, these virtual clinics will continue, except for those clients with complex problems. Next slide. I'd like to finish off with this, and I think we perhaps haven't paid enough attention to it. It's about our staff and our staff well-being. And we've been calling the COVID-19 restrictions as social distancing, but really, they're not social distancing, it's physical distancing. We are socially connected, and that's really important. And so what we're doing is we're developing a website for staff, because there's so much information out there for staff and for people around their well-being and their mental health, anxiety, depression, sleep issues, that you can overwhelm people with stuff. So what we're creating is like a sorting hat, so that people will use the WHO5, fill in the questionnaire, and if what comes out is, for example, that they've got sleep problems, then the resource that comes up tops for you to use would be something around helping you go to sleep. So that's where we're at the moment. Next slide. Be kind. I think what's worked in New Zealand is the compassionate approach, and I really think it's worth mentioning that. Thank you.
Thank you, Susanna. Thank you very much. Shalini, are you ready? And may I clarify, do we have presentations from China and South Korea?
Yeah, we do. So in the interest of time, I think we've got both presenters from China, Dr. Shen, and from Korea, Dr. Kyun Ho-jo. So what we might do perhaps is I'll go very quickly in my section, so we've got enough time for them to speak to.
Thank you. Thank you. We're running over time. Thank you.
Wow. Yeah. So I'll keep my section very brief, because essentially Australia and New Zealand are very close together. We've done very similar things in this situation, with New Zealand, I think, acting earlier and harder than we have. But essentially, we've had very few cases. We've been testing a lot. And where we're at the moment is in a similar space to New Zealand, with trying to exit and looking at exit strategies. I think with exit strategies here, I think as many people have talked about, it's trying to identify what innovations this period has brought with COVID and what innovations we want to keep going forward. post-COVID in this exit period. So looking at, what sort of accessibility and flexibility we've incorporated, what aspects of that can really be held. We've seen clients in opiate agonist treatment access care for the first time in a long time, mainly because this flexibility has been there, mainly because we've been trying to get people into treatment. So this is really an aspect I think we're trying to keep post this period as well. I think I might leave it there with just that point, because I think most of the points have been made by everyone else. And I'm really keen to hear from China and South Korea as we think more about these exit phase coming forward. So I might actually just pass over to Dr. Shen from China.
Thank you, Shalini. Thank you. Dr. Chen? Dr. Shen, can you take over? Are you with us? How many do we know if they joined from China?
He's self-muted. It would be great if you would unmute yourself, Dr. Shen, because I cannot do it from here. Oh yeah, it's okay.
Hello everyone. It's a great honor for me to attend this forum and introduce how China deals with substance use disorder during COVID-19 outbreak. As you all know, we are now in a stress environment, and the previous studies have shown that stress increases the incidence of addiction. What challenge we meet during the COVID-19 outbreak? There are two main challenges. On the one hand, the negative emotion may potentially increase the risk of substance consumption among the general population. On the other hand, negative emotion could also be acted as triggers for relapse among substance use disorder patients. How to deal with the substance use disorder during the epidemic of COVID-19? This is a difficult problem. What have we done? We have mainly done the following three aspects. One, a series of psychological lectures on how to prevent mental health problems, including disorder due to substance use disorder and addictive behavior, through a variety of media provided to patients. Two, patients with chronic disease, such as mental disorder and substance use disorder, are encouraged to use the online service. Three, Chinese Association of Drug Abuse Prevention and Treatment has developed an expert consensus and treatment guideline for substance use disorder and addictive behavior by national expert group. We have translated the expert consensus of China into English language and provided it to the organizer of this forum for your reference. During the COVID-19 outbreak, China's addiction program has the following changes. The use of illegal addictive substances such as heroin, methamphetamine is reduced, mainly due to the isolation at home. The prohibition of cross-region movement and other anti-COVID-19 measures. All these methods greatly decreases the availability of illegal addictive substances and the prohibition of people's aggression seriously influence the use environment of illegal addictive substances. In addition, due to the obvious decrease of social activity, the consumption of social addictive substances such as alcohol or tobacco are also decreased. The impact on gambling is divided. The offline gambling is significantly reduced, but online gambling is significantly increased. At the same time, the use of the internet is greatly increased in China, which would increase the risk of internet addiction, especially game disorder. That's all. Thank you, Chairman.
Thank you very much, Dr. Shen. Great.
Thank you.
China. Let's move on with a colleague from South Korea, Dr. Quen.
Yes, Nice to meet you. I'm from Korea, and sorry for not providing any slide. I just say shortly.
Have we misspelled your name? Have we misspelled your name?
Yeah, my name is Hyunho Jo. Jo.
So, apologies.
Yeah, no problem. Nowadays, the COVID-19 problems in the way of subsiding. Today, only 4 people were newly diagnosed for corona infection, and among 3 of them are from foreign countries. We are preparing for reopen school, but many parents are anxious about that, but the process are going on. The drug use are not relatively serious problem in Korea, fortunately. So the general public and the government pay not so much attention on addiction problem during this day of COVID-19, even though most of the community services are closed. But today we have another problem. Today the Prime Minister announced the policies to stimulate the depressed economic status. Among the policies, the internet smartphone game industry promotion is occupied very important portion. The professionals of addiction medicine in our country having very big concern on this eccentric aspect of policy. Additionally, the newly developed patient today revealed as a sexual minority. So the balance is between the preventing discrimination by corona infection and keeping private information is still sensitive issue in Korea today. Thank you, that's all.
Right. Thank you very much. Very, very interesting. Is there any way you can send us? I know that we finished the presentation now. The key points of your presentation, because I would be very interested to, get back to you and discuss it further to see the challenges that you face. Is there any reason why not you can share?
And it's no problem to providing you the script and some data updating after this webinar. I'll send you.
Thank you very much. That was extremely helpful. Thank you. All right, let's move on to Bernadette from Canada to update about the managed alcohol programs.
Thank you. It's Bernie Pauly here. I'm in the at the Canadian Institute for Substance Use Research, and we're located in British Columbia, where we're just in the phase of exiting COVID restrictions. We're going to have announcements towards the end of this week. And in Canada, there's really like 10 or more different kinds of COVID epidemics. Where we are in the province of British Columbia, which is about a population of about 5 million people, we've had about 2,000 cases and 124 deaths. Our lockdown measure, we never experienced extreme lockdown measures, but we definitely had very early measures around staying home and self-isolating as well as physically distancing. So could you go to the next slide, please? In terms of people who have alcohol use disorders combined with homelessness, in the early phases of COVID, and you can go to the next one, thanks. In the early phases of COVID, there were a lot of risks that were accelerated. Many people did not have adequate housing, so were on the street, could not stay at home. Their income was severely affected by closure of recycling or bottling depots. Tourism, of course, was completely cut, so ability to panhandle, businesses were closed, so their resources and income were very limited. And at the same time, our liquor stores shifted hours, reduced hours, and in many cases were not taking cash. They would only take credit cards, which made it very difficult for people. Detox and treatment services, and again, this is in the early phase. It occurred. We are looking at potential we're in exit phase where, these services may have restrictions removed. We don't have a lot of home detox here, very little, in fact. So people, intake into detox and treatment wasn't an option. And these are individuals who are street-based drinkers. So they're in a cycle of what we call surviving drinking, where they're not able to source their alcohol. And most of shelters and other places had restricted intakes. And even if they had been available, often drinking is not allowed. So some very significant risks that were escalated. Obviously, a population that's at increased risks of harms due to COVID. Because of pre-existing health conditions, because of high levels of alcohol use. And probably the greatest concern that emerged early was the risk of withdrawal and people substituting non-beverage alcohol. I realize non-beverage looks very different around the world, but for us, it looks like things like rubbing alcohol, which was becoming readily more available in those early phases of COVID. So the concern was people switching to non-beverage use when beverage alcohol wasn't available. And we had some reports of people substituting illicit drugs who normally wouldn't have used that, and some impact of overdose. And then this is a population that faces extreme stigma, extreme marginalization, even within the street or homeless community as well. Can you go to the next slide? There are often very few services for these individuals. They're literally left out in the cold. Most alcohol harm, there are really few, if any, alcohol harm reduction interventions. And so when COVID was introduced, there was a great deal of focus on the potential of managed alcohol programs being scaled up to help people physically distance, shelter, stay in place. And managed alcohol programs are a harm reduction intervention that aims to prevent the harms of substance use. So not a treatment program, but a harm reduction program. Next slide. Managed alcohol programs have been innovated in Canada since the late 1990s. One of the earliest programs was in Toronto. It was a response to freezing deaths of 3 men. In Ottawa, there's been a lot of focus on the Ottawa program internationally. They have a documentary called The Poor. The Guardian did an article a while ago. So in total, we had at the time of COVID about 23 managed alcohol programs. And since COVID, over the last 8 weeks, we've had approximately 10 new managed alcohol programs being developed, and many more desire to develop them. In many cases, the new programs have been developed for people that are symptomatic. But in our area where I am, in British Columbia, on Vancouver Island, our focus has been to initiate managed alcohol programs also for people with very high risk drinking combined and or severe dependence to prevent some of those other harms of the risk environment that I mentioned, as well as obviously being able to isolate. So people are looking to see very much how can these programs be continued, even though they're clearly interim. And in the province of BC, we're just in the process of developing interim guidance for managed alcohol. Next slide, please. Since about 2011, our team at the Canadian Institute of Research has been researching. We have the Canadian Managed Alcohol Program study, and I'll just give you a quick 2-minute introduction to that study. Next slide. We've been looking at a number of outcomes related to consumption, alcohol-related harms, housing tenure, quality of life. So it's a large mixed method study spanning multiple years. Next slide, please. And we've published multiple findings starting at about 2016. You can see here just quickly some of the, we've looked at the key dimensions of programs, how they disrupt cycles of survival drinking, provide safer sources, safer patterns, fewer acute and social harms, and of course, people more likely to be safer and retain their housing. Next slide, please. We've also identified improvements in quality of life, fewer admissions and cost savings, and people are less likely to rebudget for essentials, drink non-beverage, or use illicit drugs or commit crime. And I want to point out they're also more likely to go to treatment. So the harm reduction program provides a basis for moving to treatment. Extremely important in these programs to look at program eligibility, because you are providing doses of alcohol, policies, and tailored dosing to prevent harms. Next slide, please. So in terms of the programs that have scaled up during COVID, the main focus has been on developing what we would call a more tailored kind of program, where there's a screening, an intake, an assessment, with alcohol management plans being developed. So it's really about maintenance or tapering if the individual wishes to taper. So it's based on client goals. This little drink calculator you see on the right is something that helps people, clinicians and others help set up. And I just want to stress, I've worked a lot with the addiction physicians, and they're always asking me about what's the dosing. And what I'm always saying is it's actually about where this person has been at. So if they've been drinking, 10, 15, or 20 standard drinks a day, it's starting with that assessment and looking at what frequency of distribution, frequency of administration would be appropriate to help them to self-manage, and at the point that they're ready, make differences. We obviously have to attend to issues like delivery and storage of alcohol to places where people are, such as housing or shelters, and ongoing what we call wellness checks, monitoring for over-intoxication or withdrawal, and obviously issues related to funding. All those are being addressed. So we have a lot of new models emerging, models which have much less kind of frequency of dosing. A lot of the standard programs, dosing is 10 to 12 times a day. In these new programs, dosing is often 1 to 3 or 4 times a day. And as I mentioned, we're developing provincial guidance. Next slide. As I mentioned, in the emerging models, there's a very much a focus on self-management for individuals and moving to providing, resources that support resources and education. This is a safer drinking little guideline that we developed probably in the very early days of COVID, which is still relevant. And people have identified that it's got a nice little screening in to screen for complicated withdrawal, and then a lot of harm reduction tips. And many of my colleagues have pointed out that these would be relevant to anyone in terms of setting their goals for drinking. So very much a health promotion approach. Next slide. And in the as we go forward, we have submitted ourselves for research funds, and I'm very pleased to tell you that my colleague Tessa Parks and her team, which I'm part of in Scotland, have already received funding to look at the implementation of managed alcohol during COVID. They just recently released the feasibility study that they did prior to this, and there's been support moving forward. And the last slide, it just highlights our website, and everything that I've mentioned is on our website. The standard drink calculator is up on the right, the safer drinking tips. The map of Canada with the maps is completely outdated, and we're working rapidly to outdate it. Thank you very much.
So thank you very much for the presentation. I'm so fascinated about this program. I have been using something very similar in the UK. I call it prehabilitation approach. Use a partial controlled drinking as you use it. I didn't know about the managed programs, and I will get in touch with you definitely. Thank you very much. Let's move on. As you know, we have done, Alex, Hamid, and the PPIG, they have done the first global survey on COVID. And Alex is going to present us the initial report of the first wave of the survey. Alex, are you ready?
Thank you. Yeah, thank you, Christos. Can everyone hear me? Just thumbs up.
Yes. Yes.
Yeah. Okay. All right. I'm just aware that we only have 20 minutes left, so I'm going to be short. Just a bit of context to this. The global survey is actually one of 4 items that way back, it feels like a long time ago, way back in March 2020, the ISAM COVID-19 team in consultation with some stakeholders have decided to do. The other, if you're wondering what the other 3 are, is the webinar is the first one. Second one is a position paper, which was published in Basic and Clinical Neuroscience. And the third one was the setting up of the practice and policy interest group. So glad to say that we've achieved all of them. So if I move forward, next slide, with regards to the global survey, the aims of the survey is really sort of to try and get an opinion piece from as many practitioners as possible who are going through difficult times, not just for themselves or for the service and the systems within which they work within, but also for the patients that they're responsible for. And so we wanted to ask these individuals how substance use patterns have changed during the COVID-19 crisis in different countries, how services have been reorganized during and post-COVID, of course, depending on the country and the individuals that we're asking these questions, and what continuity and or contingencies were planned as a result. Next slide. So the survey, the questions within the survey has had several categories. I'm not going to go into the details, but I'll mention the domains. So of course, demographics of the respondent, the situational assessment, which could be around the change in illicit drug use or alcohol use. The third one, the third one is around managerial and the reaction, managerial and operational reactions and response to COVID-19 within the context of substance misuse, safety consideration for the service providers, availability and accessibility of services. Next slide. If there was any COVID-19 screening and early interventions within the substance use population, if there has been any flexibility with regards to providing what were considered as pre-COVID-19 services, and also the ability to continue or the psychosocial, not just the pharmacological interventions, and the use of, as we mentioned before, the use of online, remote, or virtual types of platforms. Next slide. And then the last questions included COVID-19 service providers with regards to have we in some way or another, has the practitioners been involved in supporting clinicians, other clinicians who are working within the intensive care unit, and if they are able to differentiate COVID-19 pathology, but also over and above that, opioid withdrawal and intoxication and other substance misuse as well within their patients. And then we homed into two special populations and encouraged this sharing of good practice. So that's the overall domains. Next slide. We started and the whole idea of the survey was that we wouldn't do it one-off because of the different phases that globally different countries were going through. But the first phase, I'm glad to say, is complete. And that's the first stage, really. At that particular moment in time, we asked the practitioners to really sort of give us an idea of what's been happening, in the context of where they are in the epidemic. The aim, perhaps slightly ambitious, but we will try. The aim is to continue asking the respondents really what's been happening, how things have changed, improved or not, and for the next 3 to 6 months. And phase 2 will start soon, I think next week. I'm glad to say that, next slide. I'm glad to say that we had 170 respondents from 72 countries. And as you can see, some countries were more enthusiastic than others. But what's important really is that we had a spread from the developing countries, rich, poor countries, European, non-European, and that is important for a global survey. We want to get some opinion piece. This is the type of slide that in this day and in this 2.5 hours of webinar is not healthy to try and understand. So we move quickly to the next one. What's important is when we look at the next slide, when we look at the initial results, mostly 95% were within the discipline of psychiatry, addiction medicine, general medicine, and psychology. Next slide. And some results which I think validates what's being discussed today and in the previous webinars is that during the pandemic, there's been an increase in alcohol use, cannabis use, a reduction in illicit opioid use. Interestingly, as I said, these are opinion pieces, opinion responses, a reduction in amphetamine use, but next slide, reduction in cocaine, increase in sedative, increase in prescription opioids, and an increase in behavioral addiction, especially gaming and gambling. Next slide. Okay, so that's more repetition of, but what's important is globally, there hasn't been any changes from the first stage, any change to resources and budget allocation for treatment and or harm reduction services, and there hasn't been any shortages in opioid medication for maintenance treatment. But of course, there's a caveat to this, to what Stephen had said, is that countries that did not have enough medication, I'm not saying that within the survey that there has been adequate type of medications. Now, again, these are just shots of some of the responses. I'm going to speed up a wee bit here. Parnian, if you go to the next slide. Interesting observations, mobile center and outreach groups encounter serious limitations regarding lockdown policies. Shelter halfway houses to the homeless have been limited, including limiting medical and psychiatric care services for our patient population. Not enough PPE, no surprise about that. And the OST clinic service became more flexible during the pandemic, longer prescription, more take-home dosages. So I think we move on to the other slide. Next slide, Parnian. We move on. Yeah. So that's just a reflection. It's just there's much more data. But of course, the importance of this is that we're able to share this data with as many people as possible. So first of all, thank you for the respondents who found the time to complete this questionnaire during these very busy times. But what's important now is that we look forward to the 170 respondents to respond to the second and the third phase in order to see if there's been any change in patterns. But the overall aim is to publish this in peer-reviewed publication by around December 2020, follow up through ISAM webinar specific topics that have been identified in the survey, such as discussing in more detail online interventions, discussing around special populations, and also sharing this information with international organizations like WHO, UNODC, MCDDA, and others who've been very helpful in sharing their knowledge with us in these webinars. Thank you.
Alex, thank you. Thank you very much. That's a very, very interesting piece of work there. Shalini, we have 10 minutes for 9 minutes for a discussion. Do you want to cover how we're going to do that? Do we answer to the questions over the chat box, or do we conclude?
In the last 10 minutes, if anyone has any questions for the speakers that they were holding over from before, if you want to pop that in the chat box, that would be great. I think just bringing everyone's attention, I think Bernie posted a couple of links as well to a conversation article on managed alcohol. And there have been some other resources as well posted in the chat section. So if you want to have a look at that. Does anyone have any burning questions for the presenters before we start to wrap up? Just bringing everyone's attention, we've got a link up in the chat section as well for registering for the Policy and Practice Interest Group itself. So we've got a mailing list set up. And if you scroll up in the chat box, you'll be able to see the link and click through and register. That will put you on our mailing list. So if we've got any more webinars, any events, anything coming up, you'll be automatically notified of that. Christos, did you have any questions for any of the presenters?
I will liaise directly with the colleague from South Korea, as I said, and definitely the Canadian experience of using alcohol as if it was medication, a type of harm reduction approach, is extremely interesting for me. I think what we have seen is that flexibility in our clinical practice, a lot of innovation to cope with the crisis. There has been strong spirit of mutual support and coming together, both within teams, nationally and internationally. Good examples of coming together. But we have to keep in mind, I think, that there is a second wave of not the epidemic itself, but of the results of the measures we took to cope with the COVID. I mean, about the unemployment, and we have to be very careful to protect and speak up for our population. It has been already marginalized. We shouldn't allow this to compromise them further. Return to work, whatever the unemployment is going to be. So what sort of reintegration could we achieve over the next few years? There might be reduction of our resources, who knows? And of course, as I say, we have sacrificed a lot of our democratic principles and actions and attitudes in order to cope with the crisis. And as we exit in this, we need to be careful to keep the good innovations, but also fight for democracy as we know it. And that is what I learned from this interesting experience in my personal and professional life. So I don't know if someone else would like to add to my summary, and then we can go the next steps.
Can I jump in with a quick comment? Just wondering if there's a danger of comparing apples and oranges, because I wondered with South Korea, is their problem predominantly stimulants, and then we're worrying about managing opiate dependence in the Western countries. So, you know, because I had hoped to hear about the marriage of the South Korean tracing system for COVID and drug misuse treatment, but it may well be that there isn't a similar system around drug misuse treatment. We have yet in Stirling, where I work, to get going with actually COVID testing the people who say they can't go to the pharmacy because they've got symptoms. So we're in for still a long haul, and how we bring testing for COVID into the drug treatment system, I think that story hasn't been resolved yet.
Can I just also add, I guess it's echoing the earlier point about, you know, most of the recommendations that we hear now relate to making sure that people have low threshold access to harm reduction, needle exchange, opioid agonist therapies. You know, harm reduction has been woefully underfunded for a number of years. But of course, during this particular crisis, it's the very thing we point to as needing and having to increase provision of. You know, I would hate to think that we perhaps forget just how catastrophic the situation is in terms of funding for harm reduction across the globe, or acceptance for it. And so maybe we just also have to be mindful of that when we consider next steps and the advocacy that's needed. The advocacy that's needed at the domestic level, the regional level, and internationally for enhanced support and funding for harm reduction. Sorry, stop talking.
Right. Shalini, should we talk about the next steps? Right. Okay, I will do that. So the final webinar on COVID, if everything goes all right, and we don't have any surprises with the way the pandemic evolves, will be on the 23rd of September, exactly the same time as it was for each one of the countries. And be about lessons learned and the way forward. I will get back to you with more ideas. Don't forget that the ISAM conference is still happening in Canada, is that right? In November. And it might be a good idea if, as PBI, we consider having a session on COVID management, putting together the presentation and having a kind of joint presentations to a second position paper, what we have learned, not a continuation paper from the first position paper, potentially. As we're talking about the ISAM conference, as you know, for the PIG, there were a lot of other initiatives. There were some colleagues who were interested in mothers, women's and mothers' substance use treatments, that aspect. Shalini is leading the discussion how we're going to arrive to either a concession paper or a position paper. Again, we can use the ISAM conference for a session there. We'll look into that over the next week or so. There is another small group regarding pain management for people who are addicted to opioids. And of course, there is the special interest group, a subgroup on telemedicine, how we can use innovations developed or enhanced during the COVID for future treatment. So all those interest groups within the PPIG will meet, discuss, look how we're going to take that forward. Have I forgotten anything, Shalini?
I think that's it, and I think we're 1 minute off from finishing, so it's a good closure.
Yeah. Can I say one thing, Christos, Shalini? That's okay. Yeah, it's just to thank Parnian and Hamed here for doing a fantastic job, not just with this webinar, but the previous webinars, in providing the support and and for Parnian multitasking and keeping evil spirits at bay, as much as continuing with such an interesting webinar. So thank you very much, Hamid and Parnian. And I'm specifically mentioning you too because there's been a very interesting transition period and the baptism of fire for the co-chairs of the Practice and Policy Interest Group, which has been formed only 3 weeks ago, and they were tasked to not just chair but also organize some aspects of this webinar. So we wish them good luck, but we also thank Parnian and Hamid for the amazing work that they've done.
I also want to say thank you very much for organizing that. I know this is hard work, and thank you, Christos, for chairing this. And to all of you, thank you very much. One question I have from many of people here in Strasbourg and around. Will this be available on YouTube after, or okay?
Yeah, it will be available on the ISAM website. And again, Parnian is the right person to tell us more about that.
Okay.
All the materials will be emailed to you subsequent to the webinar. The slides, the video recording, and everything. So don't worry.
Once again, thanks to all.
And to complete this, I would like to echo what Alex have said. Thank you, Hamid. Thank you, Parnian. And most of all, Shalini, thank you very much. The only thing I have done for this webinar was just to chairing today. Shalini has done all the hard work, taking over from Parnian and Hamid. Without Shalini, we wouldn't be able to have that webinar today. Shalini, thank you very much.
And thank you, Parnian. Thank you. Thank you, everyone. Thank you for joining. See you next time.